Well, welcome everybody. Good evening. I think I know a lot of people out there, but in case you don't know me, I'm Miguel Reguero. I'm the chair for Digestive Disease and Surgery Institute at Cleveland Clinic. And we welcome you to this live from Cleveland Clinic program. And before I turn it over to Florian and then Ben, this is something we've been doing for actually a little over a year, and this was really emerged from the pandemic. However, we realized the power of these live virtual conferences. We have people from all over the world joining us again tonight. First and foremost, I hope everybody out there is healthy and safe. We realize that we're in a fifth or sixth surge, depending on where you are in the world, and it's impacting everybody. So we appreciate your time with us this evening. We have another great program that's going to be very interactive. We're going to focus on extraintestinal manifestations in IBD. And with that, I will turn it over to Flo. And Flo, I'll let you introduce yourself, and then Ben, and then take it from there. So thank you, and I'll come back at the panel, but I'll be listening and behind the scenes now. Thank you.
Thank you very much, Miguel, and a lot of credit to you for establishing this program. It has been a huge success as we go through all the clinical topics in inflammatory bowel diseases, and today extraintestinal manifestations in IBD. And as you saw on the map, more than 500 healthcare providers are joining us today from nearly 60 countries. And this would not be possible without the sponsorship from our partners, in this case, Ferring Pharmaceuticals, Medtronic, BMS, Janssen, as well as Olympus. So we are very grateful for their support. We have an outstanding faculty that is coming from the Cleveland Clinic. I just met Dr. Reguero as one of the organizers, as well as my co-section head for inflammatory bowel diseases, Dr. Benjamin Cohen, as well as myself. I'm the co-section head for inflammatory bowel diseases and the vice chair for the Department of Gastroenterology, Hepatology, and Nutrition. And I'm going to introduce in detail for the talks each of the other faculties, Dr. Carey, Dr. Falloon, Dr. Fernandez, and Dr. Hasni, but they present our interdisciplinary care team for inflammatory bowel diseases at the Cleveland Clinic and the interface of extraintestinal manifestations in our patients. You can interact with us, and we in fact would really like to interact with you in the chat box. So during the talk and at any time during the presentation, you can just type your questions or comments into the chat, and we are happy to take them and carry them to the panel. The structure today is we're going to have 4 brief presentations with a brief Q&A in between them, and then I will hand it over to Dr. Cohen, who will manage a case presentation and a case expert panel with extraintestinal manifestations in IBD. And now I would like to ask to pull up the first presentation. The first presenter today is Dr. Catherine Falloon, and you may wonder, why does a GI fellow present at a global meeting like this one? And I can tell you why, because Katie is not a regular IBD fellow. She's the editor-in-chief of the ACG Case Report Journal. She won the editorial fellowship for clinical gastroenterology hepatology. She ran a national Delphi panel on management of extraintestinal manifestation that's going to be submitted soon, and she built a national network to study extraintestinal manifestations in IBD. So she is already an expert, is joining us as our inflammatory bowel disease fellow, and we are currently working on retaining her as staff, even though she hasn't even finished her regular fellowship. So Katie, thank you very much for doing this. And she will talk to us about the ABC of EIMs as an initial overview. I hand it over to you.
So much, Dr. Reeder, for the kind introduction. I'm excited to talk to you all today about extraintestinal manifestations. So the goals for my portion of the talk are to provide an overview of epidemiology of EIMs, to provide an overview of their relationship to disease course, and then to briefly review treatment paradigms. So first off, why learn about EIMs and have this session today? So extraintestinal manifestations are going to impact a significant portion of IBD patients. We'll talk a little bit more in a few minutes about numbers, but this really is represents a big problem in our IBD patient population and is going to affect the majority of patients with IBD. And once a patient develops one extraintestinal manifestation, they're at increased risk of developing others. So it's important to kind of know what you're looking for and to be on the lookout for these manifestations. And they will have a significant impact on the care of your IBD patients. They'll influence not only how you manage the extraintestinal manifestation, but also how you manage the IBD. So to start, just a really broad discussion of what EIMs are. As the name implies, they're basically any manifestation of IBD that's outside the luminal GI tract, and they can affect almost every organ system in the body. So you can have ocular extraintestinal manifestations, which are important to recognize early because they can be vision threatening. They can affect the heart. They can affect the liver, and in patients who have PSC, they influence how often you do colonoscopies for screening for malignancy in your patient population. The most common manifestation is actually arthritis, which we'll hear about more later on in this session. They can also affect the blood and the bones, including with metabolic bone disease, osteopenia, osteoporosis. They can influence the genitourinary system, including with kidney stones. Increasingly recognized are pulmonary manifestations of IBD, which can be both clinical and subclinical, and then a number of dermatologic manifestations, which we'll also hear about later on in this talk. So as I promised, we'll talk a little bit about prevalence. Extraintestinal manifestations are very common. I'm highlighting for you here data from the Swiss IBD cohort. This is from 2006 to 2010, and they looked at frequency of extraintestinal manifestations. And as you can see, EIMs were prevalent in about 40% of patients in this study, slightly more common in Crohn's disease than in UC. Most patients had just one extraintestinal manifestation, but you can see that a few unfortunate patients actually had as many as 5. And as I mentioned, arthritis was the most common in this cohort and in other cohorts looking at this. But there were other manifestations that also had significant frequencies, including ankylosing spondylitis and uveitis and Erythema Nodosum, less common PG and PSC. In terms of when EIMs present, I'll direct you first to this graph on the left side of the slide. This is again from that Swiss IBD cohort study. The red line in the middle is time 0, and that's looking at diagnosis of IBD. And you can see most patients within EIM present after diagnosis, but there is a significant signal to the left of that red line too, where extraintestinal manifestations are the first presenting sign. And if you look here on the right, it's going to be 25% of your patients who have EIMs as their first sign of IBD, and then 75% present after diagnosis. And by 30 years, 50% of patients are going to have an EIM. And I think this is really important to keep in mind because we're working on diagnosing IBD earlier in the course and preventing progression of disease that isn't possible to treat without surgery. And EIMs can really be a first marker of IBD and a way to capture these patients early. So it's something you should be in the lookout for right away, and then something you should keep in mind throughout the course of a patient's IBD. In terms of EIM and IBD activity, it can be a little bit hard to keep track of which EIM goes along with or doesn't go along with the IBD. So I just included this graph to highlight for you. You can see that peripheral arthritis really varies. We'll talk about this more later on as well. In the GI literature, there's some discussion about type 1 versus type 2. But in the rheumatology literature, they don't use that nomenclature, and so it really can be hard to say. For axial arthritis, classically, it's independent of disease activity. Erythema Nodosum almost always parallels disease activity. Pyoderma can vary. Sweet syndrome and Enthes Dactylitis classically parallel disease activity. And then keep in mind for your ocular manifestations, episcleritis and uveitis are both vision threatening. Episcleritis parallels disease activity and uveitis does not. PSC, some people will say independent, but really it can vary with the IBD activity. In terms of how you manage these patients, optimal management is really not well studied and there's limited data. So it can be hard for providers to decide what to do. A lot of the data that we have is retrospective, very limited prospective or randomized controlled trials. I did include for you here, there is one guideline that you can turn to that was actually published in Europe by the Crohn's and Colitis organization. It was just published in 2015 and is a good resource for you if you're looking to understand EIMs better and to have some guideline-driven management for what to do for these patients. In terms of treatment pathways, the specific treatment is going to depend obviously on the extraintestinal manifestation. A good rule of thumb is that if there's any relationship to disease activity at all, a first step is to treat the underlying IBD and seeing if getting the IBD into remission can help with your extraintestinal manifestation. And then I do want to highlight here as well the importance of referrals to the appropriate subspecialists. We have a multidisciplinary panel here with us today, and these extraintestinal manifestations, as I've highlighted, really can have devastating consequences for patients if they're not managed well. They can be hard to diagnose, and they can really influence quality of life. So if you have any questions or concerns, go ahead and refer to the appropriate colleague. In terms of what you're going to do with treatment, always keep in the back of your mind a biologic. I've highlighted just 2 studies for you here. As I mentioned already, there aren't too many prospective or randomized controlled trials out there. But the first one looked at infliximab for Pyoderma Gangrenosum. In this study, 19 out of 30 patients included had IBD. So small numbers overall, but a good proportion with inflammatory bowel disease. And 70% had improvement and 31% went into remission with infliximab. And you can see here, this is an example from that paper where there's the pyoderma adjacent to the stoma here that's resolved by the end of the clinical trial. But it's important to keep in mind too that we're looking at 31% remission only, so highlighting that these really can be hard to manage. The other study I included for you looks at adalimumab for axial spondyloarthritis. This was a much larger study. It had 185 patients, but of those, only 10 had IBD, so we were representing a fraction of the population here. However, adalimumab was effective for controlling disease activity, decreasing inflammation, and improving quality of life. So not great data, but some data to support your use of biologics to treat kind of the EIM and the IBD. I do want to highlight again that more research is needed, and there's a lot of unknowns in the field and a lot of debate in the literature. So as an example of that, I just wanted to highlight vedolizumab. So this is our gut-specific biologic, so obviously there's question of whether or not it can be used for extraintestinal manifestations. And there was one study that suggested vedolizumab actually means your patients are at increased likelihood of developing an EIM. But there was another study that was looking at a post-hoc analysis of the Gemini trial that showed it actually was associated with a reduced likelihood of new or worsening arthritis or arthralgia in Crohn's disease, and no increased incidence of these events in ulcerative colitis. So really nothing to guide you here about whether or not vedolizumab is something that you should or shouldn't be using in your patients with extraintestinal manifestations. Overall, in terms of the key take-home points for you, one is that extraintestinal manifestations are common. You're going to see them. You should be on the lookout for them, and you should have some sense of how to manage them. Definitely enlist your colleagues for help when needed. Rheumatology, dermatology, ophthalmology, hepatology, to make sure that you're optimizing the care of these patients. When in doubt, consider a biologic. And really, anti-TNFs are the biologics with the most data. There is some case reports and other anecdotal evidence for other biologic therapies as well. And more data and prospective studies are really needed to determine how to best manage this patient population and take good care of our patients. And thank you so much.
So Dr. Falloon, thank you very much. This was an important starting point for our seminar today because we now have a good understanding of the landscape of extraintestinal manifestations. And while the questions come in the chat box, I have a couple of questions for you. So how do you recommend to screen for extraintestinal manifestations in clinic in your IBD patients?
So I think that I know everyone has a busy clinic and is trying to move through, but I think it makes sense to ask certainly about the most common joint, eye, and skin and then also give patients a chance to mention anything else that might be going on. And in my practice, I've actually started looking a little bit also at pulmonary manifestations, because there is emerging literature that a number of these patients have significant changes in how they breathe and in their oxygenation and their PFTs. So I think just kind of spending a couple minutes going through and making sure, and then asking your patients if they have anything else to add.
So I completely agree with you. Do you screen for subclinical extraintestinal manifestations?
I do not. That's an interesting question as to whether we should be starting, but I only look for overt.
Okay. There's a question from Dr. Murad for you. Can extraintestinal manifestations present as a chronic kidney disease, or should they always be attributed to drug-induced AKI? And then what are the preferred biologics in such patients with chronic kidney disease?
So I think that's an excellent question. One of the things that's so hard about extraintestinal manifestations in general is what do we attribute to the medication we're using to treat the IBD, and what do we attribute to the IBD itself, and it can sometimes be unclear. I think I would have a high suspicion for a drug-induced, especially in like your 5 ASAs and things like that. In terms of biologics, I usually don't have as much concern. I would make sure also to screen for all the other common things that can cause chronic kidney disease, especially as the IBD population ages. And then in terms of preferred biologic, I would be comfortable using any of the standard biologic therapies in patients with renal dysfunction.
Okay, very good. I agree. Just one brief editorial comment, but this is in our routine lab, so it's not, we don't technically screen extra for it. So in our IBD patients, we have alkaline phosphatase in our routine panel on the routine visits, usually every 3 months, to screen for presence or evolving primary sclerosing cholangitis. But this is part of our routine, so technically not a screening of an asymptomatic, but I just wanted to put this as an editorial. So thank you very much, Dr. Falloon. It was a really good presentation. We're going to move on to the next one, and it's my pleasure to introduce Dr. Fernandez. Dr. Fernandez is a dermatologist and dermatopathologist, is a director of medical dermatology at the Cleveland Clinic and the W.D. Stack Chair of Clinical Dermatology, and is our go-to person for any complicated skin manifestation associated with inflammatory bowel disease. So it's a great honor for us to have you here, Dr. Fernandez, and thank you for joining. The stage is all yours.
And I'm a dermatologist and dermatopathologist here at the Cleveland Clinic, and I'm going to talk to you this evening about the extraintestinal cutaneous manifestations in IBD patients. Here are my disclosures. None of these activities impacted the content or formulation of this presentation. The cutaneous manifestations of IBD can broadly be categorized into 2 groups: specific manifestations and reactive manifestations. Specific manifestations imply that the disease pathogenesis is identical to that of the underlying IBD. And these are rare and essentially confined to patients with Crohn's disease, with the main specific manifestation being metastatic or cutaneous Crohn's disease. Reactive cutaneous manifestations imply that the disease pathogenesis differs from that of the underlying inflammatory bowel disease. These are much, much more common and what you're more likely to see in your patients. And that's what we're going to focus on this evening over about the next 10 minutes. And specifically, what I'd like to focus on are the 3 most common cutaneous reactive inflammatory EIMs that you're likely to encounter in your IBD patients, namely Erythema Nodosum, Pyoderma Gangrenosum, and Sweet syndrome. So let's start with Erythema Nodosum. Erythema Nodosum is arguably the most common cutaneous manifestation of IBD. It's been estimated to occur in upwards of 4 to 6% of all IBD patients. Erythema nodosum, as Katie alluded to, occurs more often in Crohn's disease patients than ulcerative colitis patients. There is a female predominance, and it usually occurs after patients have had a confirmed diagnosis of IBD. And importantly, also as Katie mentioned, erythema nodosum parallels underlying intestinal disease activity. Erythema nodosum typically presents as sudden onset of symmetric erythematous to violaceous, warm and tender nodules. And these far and away most likely occur on the lower extremities, especially the anterior tibial areas. But rarely they may occur in unusual anatomic locations. And it's also not uncommon for patients to present with various constitutional symptoms in addition to these cutaneous nodules. Here is a typical photograph of patients with Erythema Nodosum, and I think you can appreciate that this patient has relatively nonspecific erythematous nodules on her bilateral lower extremities, focusing on the anterior tibial areas. And because of the nonspecific nature of this clinical presentation, the differential diagnosis of Erythema Nodosum is relatively broad. It includes all paniculitis type lesions, as well as metastatic Crohn's disease, skin infections, and various autoimmune diseases. But despite this broad differential diagnosis, oftentimes the clinician can make a diagnosis of Erythema Nodosum simply by evaluating the patient clinically and thinking about the clinical context in which the lesions are presenting. However, when the diagnosis is uncertain, a lesional skin biopsy can distinguish Erythema Nodosum from these other entities because the histologic picture is quite specific. In this photomicrograph, we see normal skin, and at the inferior aspect of this picture is where the subcutaneous fat is. And the arrows here are highlighting fibrous septae, which are collagen-containing structures that extend down from the dermis and envelop the subcutaneous fat lobules, adding some sort of structural support. And it is these fibrous septae that are the focus of inflammation in Erythema Nodosum, such that in lesional biopsies, we see widening of these fibrous septae because of a relatively dense mixed inflammatory infiltrate. And in the right-hand photograph, hopefully you can appreciate that sometimes the inflammation is so intense that you can hardly tell that there are fibrous septae there. They become so widened. A typical course of Erythema Nodosum lasts for about 3 to 6 weeks. And a lot of cases are self-limited. You do not always have to prescribe medical therapy for these patients. Sometimes supportive measures such as leg elevation or over-the-counter analgesic medications or compression stockings are sufficient. But for more severe disease courses, the treatment of choice is a relatively short course of oral corticosteroids. And also, as Katie alluded to, because Erythema Nodosum parallels underlying intestinal disease activity, TNF-alpha inhibitors can be used as rescue therapy in the more severe cases of Erythema Nodosum. Pyoderma Gangrenosum is also another important and relatively common cutaneous EIM that you're likely to see in your IBD patients. Pyoderma Gangrenosum is a neutrophilic dermatosis that typically creates skin ulcerations. The prevalence of PG is estimated to be between 0.4 and 2% of IBD patients. Like Erythema Nodosum, PG typically occurs in patients who already have a confirmed diagnosis of IBD, but unlike Erythema Nodosum, PG tends to occur more often in ulcerative colitis patients than in Crohn's disease patients, and PG does not always follow the course of the underlying IBD disease activity. Pyoderma Gangrenosum typically presents as an erythematous papule or pustule that rapidly enlarges and eventually forms ulcerative lesions in the skin. And these ulcers are variably sized, they have granulated bases, and importantly, they have undermined borders that often have a so-called gunmetal gray hue. Pathergy, or the appearance of Pyoderma Gangrenosum lesions at sites of previous trauma, is one of the hallmarks of this disease. And in theory, this implies that PG can occur anywhere on the body, but in reality, far and away the most common areas where we see Pyoderma Gangrenosum is on the lower extremities, and in IBD patients also in peristomal areas. These patients often have extensive pain associated with their ulcers, but they too can present with various constitutional symptoms along with that pain. Here we see 2 photographs, and on the left is a patient with a relatively early Pyoderma Gangrenosum ulcer. And really, you can appreciate that this is mostly a large inflammatory ulcer, but centrally is just beginning to ulcerate. And on the right, we see a patient with a more advanced or mature Pyoderma Gangrenosum ulcer. And if you focus your eyes on the border of that ulcer, hopefully you can appreciate that undermining effect, where you get a sense that underlying that intact epidermis, there is extensive inflammation. And you can also see that characteristic gunmetal gray hue to the border of that ulceration. And this is a patient with a typical peristomal pyoderma ulceration, where again, if you focus looking at the border of that lesion, you can appreciate the undermining in that gray hue. The differential diagnosis of Pyoderma Gangrenosum is also quite broad and includes many different diseases that pathogenically can cause skin ulcers that mimic Pyoderma Gangrenosum. Because of this, Pyoderma Gangrenosum has classically been considered a diagnosis of exclusion that involves not only performing a skin biopsy, but also numerous serologic studies and sometimes even imaging studies to rule out other disease processes. This slide shows photomicrographs of a skin biopsy taken from a Pyoderma Gangrenosum ulcer. And on the left at low power, first I want you to appreciate that the epidermis is intact. It is important that we take the biopsy from the border of an ulceration, not in the ulcerated bed. And underlying that intact epidermis, there is a dense inflammatory infiltrate that extends deep into the dermis. And if we had photomicrographs at even higher power, we would appreciate that most of those cells are neutrophils, and there's scattered areas of central necrosis as well. Treatment for Pyoderma Gangrenosum really depends on the size of the ulcer. For very small ulcers, you can consider topical steroids and or intralesional Kenalog injections, but the vast majority of Pyoderma Gangrenosum ulcers require systemic treatment, with oral corticosteroids really being first-line treatment, but it is very common for us to use a variety of steroid-sparing immunosuppressive agents. And in the setting of IBD, Pyoderma Gangrenosum can be treated with TNF-alpha inhibitors, and these are actually considered first-line treatment for PG in IBD patients. And I do believe that they work much better to treat PG in IBD patients than when PG occurs in other settings in patients with other underlying disorders. And finally, Sweet syndrome. Sweet syndrome is another neutrophilic dermatosis. It occurs more often in women. It seems to occur more often in Crohn's disease patients than ulcerative colitis patients. And like Erythema Nodosum, it seems to parallel the underlying IBD disease activity. Sweet syndrome typically presents with erythematous papules and plaques, but this time on the upper extremity. And in fact, the most common areas of involvement are the head and neck, although the upper extremities can also be involved. And sometimes these lesions have a targetoid-like appearance to them when they are fully developed. Patients with Sweet syndrome also can present with various constitutional symptoms. And if you order lab work, a CBC will often show a peripheral leukocytosis with an absolute neutrophilia, an elevated sedimentation rate, and other inflammatory markers. Here are pictures of a typical presentation of Sweet syndrome, and you can appreciate that in this middle-aged gentleman, he has numerous erythematous papules and plaques on his forehead and in a periorbital area, but he also has lesions on his palm that have sort of a vague targetoid appearance to them. Sweet syndrome can be distinguished from other disease entities by a lesional skin biopsy. And the histologic features of Sweet syndrome include, first of all, usually extensive superficial dermal edema. And I think you can appreciate that in this photomicrograph, where it looks like the epidermis may not even be attached to the underlying dermis because of the extensive superficial dermal edema. And below that edema, there is a fairly dense inflammatory infiltrate composed mostly of neutrophils. Treatment for Sweet syndrome, first line is a short course of oral corticosteroids, but in outbreaks that are more persistent or more severe, we do sometimes add steroid-sparing agents, especially agents that are exquisitely good at controlling neutrophilic inflammation, such as dapsone and colchicine. And again, because Sweet syndrome typically parallels underlying IBD activity, you can also utilize medications that are effective in treating IBD, such as TNF inhibitors and/or azathioprine. So in summary, the cutaneous extraintestinal manifestations of IBD are relatively common and add significant morbidity to underlying IBD disease. And recognizing the more common cutaneous extraintestinal manifestations is important because, as we've seen, some of these actually indicate that there's underlying intestinal disease activity and may also indicate that treatment changes are needed for controlling the IBD. And in terms of the cutaneous EIMs, treatment strategies really vary based on the severity of the outbreaks. However, oral corticosteroids and TNF inhibitors can often be effective when involvement is significant. Thank you.
Thank you, Dr. Fernandez. This was excellent with the most common extraintestinal manifestations. And I want to share with you that during your presentation, I got a text message that you look much younger than I do. But this is off topic, so we're not going to dive into this. We're just going to have a couple of questions. There are actually a lot more that we're trying to capture also in the case presentations later, and Dr. Fernandez will be part of the case panel. So one question was about hidradenitis suppurativa. Is this considered an extraintestinal manifestation? And when do you consider it in your differential?
That's a great question. I mean, I guess in theory, you could consider it an extraintestinal manifestation in the same way, you know, Katie showed a slide where psoriasis was categorized as an extraintestinal manifestation. I tend to think of it as a disease that shares many features with IBD and therefore is associated in patients that are at higher risk. Mainly because it's chronic. You know, I think of things like hidradenitis suppurativa and psoriasis as distinct disease entities, mainly because they're chronic, whereas the diseases that I sort of focused on in my presentation may come and go, and your goal is to cure the patient of those diseases, at least their current outbreaks. Hidradenitis, we consider when we see the appropriate clinical lesions in the right clinical context. So inflammatory papules, abscesses, draining sinuses that typically involve intertriginous areas of the body. The axillary vaults, inframammary areas, and the groin are most common. And Flo, you know, we've done talks together where we've talked about how sometimes it can be hard to distinguish hidradenitis suppurativa, especially in the groin or perianal area, from cutaneous Crohn's disease. So it can be challenging, and they do occur together. But you know, I think it's every patient's unique, and looking at the clinical context is important.
Yeah, fortunately, the therapy often overlaps. So distinguishing them, if you cannot distinguish them, you can still treat it because often you have medications that target both, like anti-TNF. One quick question, quick answer. Paradoxical skin eruptions in patients with anti-TNF, like inflammatory alopecia. When do you switch class? When you switch within class? When you consider switching out of class?
That's a great question. So we have seen that a lot over the years, and our main goal is to try to treat the eruption when their underlying chronic inflammatory disease is responding well to the TNF inhibitor. So we'll usually communicate with the physician who's prescribing the medication, because TNF-induced psoriasiform lesions, alopecia, more commonly occur in patients with underlying disorders other than psoriasis. So they're usually being treated for IBD and RA. If the medication is working, if the TNF inhibitor is working very well, then we control with topical medicines, with various systemic medicines, methotrexate, cyclosporin, as best we can. However, if we cannot control it, or if the underlying disease is not being as controlled as well as the treating physician wishes, then I think it makes sense to switch.
Okay, very good. So before, thank you very much again, and I'm impressed how you also placed one of our sponsors subtly in the background of your presentation, being on top of your microscope. So thank you very much for that. And I would like to hand it over to Dr. Elaine Hasni for the next presentation. So thank you very much, Dr. Fernandez.
Thank
So
you.
Dr. Hasni is the Department Vice Chair for Rheumatology and the Director of the Arthritis and Musculoskeletal Center, and internationally recognized as a rheumatologist, with being involved in clinical guidelines, including guidelines assessing treatment of rheumatologic disorders in patients that have also inflammatory bowel diseases. So she's in an ideal position to talk to us about rheumatoid manifestations of inflammatory bowel disease.
Thanks, Florian, and thanks to Ben and Miguel. It's so nice that I share patients with you, and now I see that, and all the administration stuff you guys do for the Cleveland Clinic, and now this world-renowned education program. So it's really great to be part of this. I'm also excited to be here because we share a lot of medications with rheumatology, and I love to hear how you and GI use some of these same biologic medications. So my task today is to look at EIMs in the musculoskeletal domain. I'm going to focus on arthritis, since I only have about 10 minutes. So I hope to keep everyone on time. So as you heard from Katie, I have read studies up to 46% have EIMs that are affected in arthritis. It has a pretty heterogeneous presentation, as we know. I picked up one statistic that I thought was kind of interesting, in that in the younger cohort of IBD, arthritis can occur as much as 25%, but as the cohort gets older, it looks like it may shrink down to 1 or 2%. So in our world, the older we get, we actually have more arthritis. So I thought that was interesting thing to see. So you are the only discipline that has renamed the way that we look at joint disease. So I'm really impressed that gastroenterologists took the time to look at type 1, type 2, and combo and type 3. So as Katie had alluded to, I probably won't speak a lot to this because in rheumatology we have a different approach, and we don't commonly use these, but hopefully some of these will translate, and hopefully we can answer some questions from your group of even how these type 1 and type 2 came about. So the way that we look at it is, as you can see in front of you, we think of it as a family of related diseases that we label as spondyloarthritis. And the circles around it are the families of different diseases. And they are all connected because they are considered seronegative. And this is an important point for us. So many of our other diseases, like rheumatoid arthritis and lupus, have blood tests that we can get, such as an ANA or a rheumatoid factor or an anti-CCP antibody. But in this disease, it is known as seronegative, and they're linked by affecting the axial spine. So they're linked clinically. And then, of course, there's a genetic marker, and we're learning more about genetics, but HLA-B27 positivity also helps, but not everybody with HLA-B27 will develop a spondyloarthritis. But if it's there, it can be helpful. The pattern of joints is a little bit different. These are all connected because it affects the axial spine, but certainly we can have patterns of joints that affect peripheral as well. And they're usually known as an oligoarthritis pattern. So what I mean by that is usually 4 or less joints. So this is very different than how we see some of the other inflammatory arthritis that usually affects many more joints than just 4 or less. So there's some new nomenclature that we have all been struggling with. So even though I say there's a family of diseases, there is sort of a camp that we call the lumpers. Lumpers meaning they kind of lump all of this into spondyloarthropathy. And then there's rheumatologists that might be considered splitters, where we want to see those, circles that you saw around. But in general, we consider them spondyloarthropathy. And then more recently, there's been approval of some medications for something called non-radiographic axial SPA. And so I just wanted to kind of highlight that little green area that you see. So for spondyloarthropathy, we have an axial form that predominantly affects the axial skeleton. And then we have a peripheral form where you get a lot of joint symptoms in their hands and in their feet. And then to make it a little more confusing, we now have something called non-radiographic axial SPA, which, just like it sounds, is that there is no radiographic evidence of spondyloarthritis, but yet they have all the other clinical signs and symptoms of AXSPA. And there is actually an FDA-approved TNF inhibitor for non-radiographic. So the way that we approach joint pain is really looking at arthralgias versus arthritis, looking at non-inflammatory versus inflammatory, and then the importance of understanding central sensitization. So what is the difference and why do we care? So both arthralgias and arthritis are going to present with joint pain. They're going to, just talking to the patient alone is probably not going to be as helpful as also adding some imaging and exam findings. And so even though here's a cartoon picture that I use for my trainees, so in a healthy joint, you can see nice smooth cartilage surfaces surrounded by a nice thin joint capsule and synovial membrane. And people with healthy joints can still have joint pain, and that's called arthralgias, and usually that's emanated more from the structures around. So muscle spasm, ligaments, tendinitis, soft tissue items. And then if you go over to the arthritis side, you can see a more angry looking, sort of a thin cartilage. You could see that the synovial membrane, which is where all the action starts, instead of really thin layer, it's juicy, it's angry looking. And this is what we palpate, and this is what we are trained to do to look for synovitis. We also think it's important to look at inflammatory versus non-inflammatory. This also really helps us. So if you go down the inflammatory route, when somebody has joint pain, you also want to know, is there a swollen joint? Is there redness, warmth associated? And is if there morning stiffness? Now, morning stiffness is probably one of the hardest things we try to elicit, because as you can imagine, you ask someone if they're stiff in the morning. I mean, even I'm stiff in the morning, right, if I don't have a good night's sleep. But this kind of stiffness is really different. We're looking for stiffness that lasts more than an hour, where they can't even take, when the alarm clock goes off, they can't even take the covers off because they're that stiff. As opposed to what many of us might be more familiar with is, if you sit for a long car ride or you sit for a long dinner and you try to get up, there's also initial stiffness or discomfort, but it only lasts a couple minutes. And that's more gelling, and that's more in the non-inflammatory milieu. And you can see examples of inflammatory arthritis, more like RA, gout, or psoriatic arthritis, and the non-inflammatory would be OA or osteoarthritis. So there's also another interplay with central sensitization or myofascial pain or chronic pain syndromes or fibromyalgia that also play a role. So this is sort of an older picture. These are the typical fibromyalgia, what we call fibromyalgia tender points that we're trying to get away from. But what it shows me is that sometimes they can be, near joint areas, and that makes it a little difficult for us to know, whether it's a joint, whether it's a myofascial or fibromyalgia type syndrome. So this is a picture sometimes I give to my patients for them to mark down the pain. And for this crowd, I just want you to be alerted that if the pain is sort of on the upper and the lower and the back and the front, sort of more diffuse, that's what makes, sort of central sensitization bubble to the top of my differential. And then this is actually a real case that I had when I was a rheumatology fellow, where I asked somebody to mark the pain and they started marking like above the figure. And so probably the medical student in the room here could figure out that this person probably has more than an inflammatory joint and could have central sensitization. So our approach is really to take, we don't have the luxury of doing, a colonoscopy and getting a biopsy, or in derm getting a skin biopsy. We really rely on symptoms, imaging, and lab to make the diagnosis. There are a couple of clinical things that I want to alert you to that are really cardinal features of spondyloarthritis, and that's dactylitis, or also known as sausage toes and sausage fingers. So this is really, if you see it, it may not be that common, but if you see it, it does really tell us that there's something inflammatory going on. It's also associated with radiographic damage, so it's something that we want to know about. Enthesitis is also, as you can see here, a picture of someone with a normal Achilles on the right, and on the left an inflamed Achilles, as you can see. And that's something that's very difficult to find out. Sometimes we need ultrasound because it's really right around the ankle joint as well, but it's where the tendon inserts the bone. So this is really outside the joint that can get inflamed with spondyloarthropathies. So here is, so if there's one thing you want to remember if you are so inclined to become a mini rheumatologist, and you do want to check an x-ray and somebody is complaining of possible spondyloarthritis, we actually only need an AP film of the pelvis, period. wherever their low back pain is. This alone will give us probably enough information. Obviously we can go on to MRI and other modalities, but as sort of a non-rheumatologist, if you are so inclined, just an AP of the pelvis. And so what we see here is that you can get a quick glimpse of their hip joints. And then the most important is this sort of SI joint area. And here what you see is quite a bit of sclerosis on the iliac side. And you do see a little bit as well on the sacral side. And then you can also see that you can still outline a little of the SI joint, but not great. So this is probably about, since the SI joint isn't fully obliterated, probably a grade 3 sacroiliitis. And this bilateral sacroiliitis is really what we look for to help us confirm spondyloarthritis of any kind, whether it's axial involvement from psoriatic arthritis, IBD related, ankylosing spondylitis. This is where the first joints that are affected. So this is a T2 weighted MRI, just to give you an idea of some of the more advanced imaging that we use. And here you see much more early markers of what we consider bone marrow edema in this sort of fat saturated. It really highlights the bony changes, so it gives us some early indications. But here you could see better the outline of the SI joint. So this is still early changes. And sometimes there's other sort of bony, like osteitis, condescens that can happen, that can maybe confuse us a little bit, but sometimes we would have to go on to, this is a CT image and we actually see a erosion. And once we see that, then, we kind of know it's in our ballpark, because there's no other things that would cause an erosion. And for those who really want to have a recipe, this is from ASAS, this is what we look for in terms of classification criteria. So you either fall in the blue box or the green box, but you have to have back pain for 3 months at a young age. And then what we look for is if you have imaging, if you're lucky enough to have imaging features, then you just need one of these SPA features below. If you only have a genetic marker like HLA-B27 and back pain, then you need 2 features before we can sort of classify you as SPA. So what do we need when we're working together, when we're trying to treat IBD-related arthritis? First, we really want to know, is the IBD controlled or uncontrolled? And I know that seems simple, but sometimes, as we all know, when I share patients with our GI folks, that it's not always so clear cut. But we do want to get an idea when we get the referral whether you feel it's controlled or uncontrolled, not so much only according to the patient, but also according to the referring GI. And then we want to know how many joints are involved, because that could change the way that we think about the classes of medicine. And then image findings are really important. I do want to talk a little bit about NSAIDs, because we're always looking for your blessing if we can use this, because this really is the first line treatment for SPA is nonsteroidals. And we know that many I think literature in the past was, really fraught with, anxiety about risk of flaring of Crohn's and UC. But here's just an example of a systemic review of 13 different studies looking at the association of NSAIDs and the risk of flare. And it does look like there is, not as much risk. And so love to talk about how we could, maybe get your blessing to use some NSAIDs in patients with joint pain. I also want to alert you to a study that we've done at the Cleveland Clinic called the Precision Trial. Basically, not so much looking at IBD patients, but looking at RA and OA with the different NSAIDs. So this is one of the largest studies we have. So just quickly looking at the results table, I want to hone in on, you can see on the top graph, there's really not much difference between celecoxib, ibuprofen, or naproxen. But if you look on the second line, and I'm just going to push our attention to the gastrointestinal events, as you guys all know, the COX-2 does have some, hopefully some benefit in terms of GI events. And so here you start seeing the line split up a little, where celecoxib has a more favorable profile than ibuprofen or naproxen. And then in terms of the renal events, there's also, some splitting as well to highlight from this trial. But in terms of cardiovascular events, all celecoxib was considered non-inferior to ibuprofen or naproxen. So this is just a quick treatment, not for us to go into detail, but all of you guys are familiar with all of these drug classes. The green dots are the ones that are FDA approved for either psoriasis, psoriatic arthritis, or ankylosing spondylitis. The yellow dots are the ones that are in trial, and then the red dots are the ones that have either stopped or are not approved because it doesn't work. So I just wanted you to highlight that there's a lot of red dots in the ankylosing spondylitis. And so it is quite challenging. Out of all of the inflammatory arthritides that we care for, ankylosing spondylitis has probably the least available biologics that are available to treat these patients. Early use does matter. So this is just a graph to remind you that if there's a delay in, jumping to a TNF inhibitor for ankylosing spondylitis, that we will probably incur more irreversible joint damage. I bring this up, methotrexate, really quickly because I find it really interesting how many GI do order antibodies and you're able to use that. We actually do not. We actually think of methotrexate more as our sort of go-to drug to use in combination and keep it on combination to prevent antibodies or longevity of our biologics. And then last but not least, I think, as we all know in rheumatology and in GI, that these drugs can only do so much. And we think that there is also health and wellness strategies are important. This is not an option. This is part of taking care of our patients. And each of our patients may need help in all these pillars, maybe one or two of these pillars, but it's also helpful to be mindful of other ways that we can also help them in addition to all the prescribing medications that we use. So just key takeaways is that early diagnosis is important. So it's much easier for me to take care of patients early on in their arthritic disease course than later. That presentation can be quite varying, and we need to be on alert. And hopefully, more education programs like this can help us collaborate and understand the way that we use these medicines. And I know what I've been getting recently, which is really interesting, is like using vedolizumab in combination with some of our biologics and what experiences we have with that. So thank you.
Thank you very much, Dr. Hasni. And this is a really nice segue into the questions. But one quick comment I would like to make, because it came up in your presentation, are the IL-17 inhibitors, and that's something that still may not have penetrated as much as you would like to in the GI community, that IL-17 inhibitors can induce colitis. So that's something to watch out for. And in patients with IBD, they are contraindicated unless you really don't have any other options and you work closely with your rheumatologist and you closely monitor your patients. But this is just one item that we encounter frequently, and I think it's important to remember. So there.
Yes.
Oh, yeah. Sorry.
Yes, you're correct. So IL-17, it had no chance in your field because we had so much black box warning that we would just run the other way. Even if they didn't have the diagnosis, even if they said they had any GI symptoms, we would just run the other way. It wasn't even going to be in our armamentarium. But I will say that as we're using IL-17 more, because it is really good for ankylosing spondylitis, is that we are not seeing clinically a lot of these flares that was seen in clinical trials. So I think more to come on that. But yes, you're correct. We are not using them.
So there's one question from Dr. Murad. Can anti-TNF induce peripheral arthralgias? Do we need to switch out of the class or can we switch within class, and any other specific investigations that are necessary?
Sure. So there's always those patients that, you're using these, really high-powered drugs to stop their inflammation, and they come back and they have worse pain, and you're like, whoa. So that's a pause for us. And, I wouldn't say that's common. Most of the times these medicines work well, they work fast, and, we actually see changes on their exam that are improving. But in those that, where, you think that there's a drug-induced sort of, off-target reaction, we actually have, really used musculoskeletal ultrasound, and, we use that a lot now to help see whether or not there's actually true inflammation in the joint or outside the joint, or maybe there's just something else going on.
Okay, very good. Thank you so much for leading us through this topic, and Dr. Hasni will be back in the panel. But before we come to the panel, I would like to introduce you to Dr. William Carey. Dr. Carey is probably well known to all of you as a legend in the field of hepatology. He's a past president of the American College of Gastroenterology, lead author on multiple guidelines in the field of hepatology, and I had the big pleasure to have him as my teacher when I had my training in the United States. And Dr. Carey will talk about an aspect of liver disease that is important for us in inflammatory bowel disease and treating our patients. So thank you for joining us, Dr. Carey.
Thank you very much, Flo, and I want to thank Dr. Ruggiero and Dr. Cohen for inviting me to participate in this pretty darn exciting panel. I've learned a lot already, and I hope to share with you some things that might help you in your practice as you deal with IBD patients. So I'm going to get started. We're going to talk about some liver manifestations now, and I'm going to really hone in on something that is a little not considered right away to be an extraintestinal manifestation of IBD, but in my estimation, it probably should be. So I would urge Dr. Falloon and other opinion makers, when they come up with extraintestinal manifestations, think about reactivation hepatitis B. But before we get there, I want to echo what Dr. Falloon has said, that if we look at the most common liver condition seen in patients with inflammatory bowel disease, it's really fatty liver disease, either simple steatosis or steatohepatitis with varying degrees of progression. Okay, perhaps the most characteristic or distinctive liver or hepato-biliary disease that is seen in the setting of inflammatory bowel disease, particularly in colonic involvement, that is UC or Crohn's disease with colonic involvement, would be sclerosing cholangitis. And here you can see a cholangiogram showing irregular ducts, some dilated, some strictured. And you can see a liver biopsy taken from someone with a sclerosing cholangitis with so-called onion skinning, that is laminar fibrotic areas surrounding the bile duct. Now, I have a hunch that in the case discussions, we're going to see a case of sclerosing cholangitis. I don't know that. So I want to take the few minutes allotted to me to talk a little bit about hepatitis B and why it should be important to you as gastroenterologists or other physicians caring for people with inflammatory bowel disease. Well, in the first case, there's a lot of it around the world. Like 250 million people are chronically infected with hepatitis C. And you have to add to that people who have gotten over their active phase of hepatitis B, but now are anti-HB core positive. All of these people are at risk for some bad effects when they have inflammatory bowel disease that is severe enough to require potent immunosuppressive therapy. Here's a fairly recent study from China, as it turned out, indicating that the incidence of anti-HB core in patients in China with inflammatory bowel disease is a startling 41%. Okay, it varies a lot throughout the world. It's also pretty apparent wherever it's studied, either in the context of IBD or not, that compliance with vaccination is really not very good, not optimal at all. It's further known that IBD patients who receive immunization against hepatitis B don't develop antibodies as frequently as normal or non-IBD patients. And then the last and most important reason why I want to highlight this in my time is that reactivation hepatitis B can be lethal. We took a look at a patient at the Cleveland Clinic who received rituximab therapy, and we found that 37% of those who developed reactivation died. So it's not a trivial problem. It needs active attention and intervention where necessary, and I'll talk you through some of this. So immunization against hepatitis B, highly effective when it is completed. Lots of problems with immunizations, as we know about today in the COVID-19 era, but there's always been difficulty in getting all people who ought to be immunized against hepatitis B actually immunized. And part of this stems from the usual immunization strategy, which calls for 3 immunizations over 6 months. That's a very hard thing to implement, particularly in adults who have busy lives to lead. Here's a study indicating that IBD patients are not as likely to develop protective antibodies in response to immunization. Anti-HBs of greater than 10 is felt to be the minimal requirement for active protection. And in IBD patients, only 80%, whereas in controls, 94%. And if you look at a higher standard, anti-HBs of greater than 100, you're down to less than half of individuals with inflammatory bowel disease develop that level of antibody protection. So this is a problem that we need to address. So here is a new vaccine that was approved in 2018 in this country. Instead of 3 immunizations over 6 months, this requires only 2 immunizations 1 month apart. So on a practical basis, this is much more easy to administer, and hope that you'll get your patients back for 2 immunizations. Moreover, if you compare the new vaccine with the standard vaccine, it is more immunogenic, right? 13.7% more immunogenic in one series and almost 20% more immunogenic in another series. I'm unaware, I could find no specific studies of relative immunogenicity in inflammatory bowel disease patients. So that's a study that perhaps ought to be done. So I'm not going to bore you with great detail about the way that we classify those with hepatitis B, with chronic hepatitis B, except to point out that we broadly define these into those who are E antigen positive and those who are E antigen negative. And for the most part, we're only interested in treating people who have active disease, that is phase 2 or phase 4 disease, okay? And then you'll see phase 5 is resolved hepatitis B. Perhaps a somewhat easier way of looking at this is to look at this in a schema like this. In the blue, we see perinatal transmission of hepatitis B. That's how most people around the world get it. Whereas in this country and in low prevalence areas, horizontal transmission, that is in young or late adolescence, early adulthood, these folks get E antigen positive, immune active disease. And then after a period of time, the E antigen may go away to replaced by its antibody anti-E, okay? So if you have surface antigen positive but E antigen negative, you have less disease, inactive hepatitis B, and then some of these individuals will actually clear their surface antigen. And you might say, well, if they've cleared their surface antigen, they must be cured, okay? But the fact is that both those who are surface antigen positive and surface antigen negative, as long as they're anti-hepatitis B core antigen positive, these people are at risk for developing reactivation. Well, how is that possible? How is it possible? Those at risk are anti-HB core positive, anti-HBs negative. And the reason for this, of course, is hepatitis B, kind of like the chickenpox virus, never really goes away. It kind of sets up shop in the cell nucleus of the hepatocyte as cccDNA, and it kind of stays there more or less forever. So anyone who has been exposed to hepatitis B is at risk for reactivation, although those who are surface antigen positive are far more likely. Now, the reason that this is important in the context of this meeting is that a lot of the drugs that are used for management of inflammatory bowel disease are the very ones which are likely to cause hepatitis B reactivation. And B-cell depleting treatments are the most likely, whether you're surface antigen positive or negative, okay? On the other hand, if we look at the low-risk azathioprine, 6-MP, methotrexate, short-term low-dose steroids, etc., these are relatively low risk, and you can see a whole array of immunologically active drugs in that moderate category. And what we do about patients who are exposed to these drugs is quite important in terms of preventing hepatitis B reactivation. A fairly busy slide, and again, I'm not going to go into all the details there except to say that if we're talking about, I think my arrow will show it, if we're talking about those who are surface antigen positive, if they have active disease, of course you're going to treat them. If they have inactive disease, low viral loads, normal ALTs, and they're given a high-risk drug that I've shown you on the preceding slide, they should be given preemptive nucleoside analog therapy. And the same goes for those who are at have moderate risk, that is, drugs from the moderate risk category. Those too should be given anti-hepatitis B nucleoside analog therapy. The low risk, however, should be just monitored. On the other hand, if they're surface antigen negative, but they're anti-HB core positive, they are at risk. And in fact, in our study on rituximab, more of our reactivation patients came from the category of individuals who are surface antigen negative, anti-HB core positive, than came from those who are surface antigen positive. So again, high risk, they should be given nucleoside analog treatment. If they're on a moderate risk, then opinion is divided about whether monitoring or active nucleoside analog treatment is the right thing to do. I personally think that the consequences of reactivation are so severe that nucleoside analog treatment should be given quite liberally. Which ones to give? Those with lack of resistance create 3 winners, entecavir or 2 forms of tenofovir available widely throughout the world. These are the ones which really predominate in terms of their effectiveness, and so these are the ones that are generally recommended. So I'm going to conclude by arguing that hepatitis B reactivation is a risk for anybody with inflammatory bowel disease who needs treatment, and that all with inflammatory bowel disease should be screened. And they should be screened most importantly for anti-HB core, but also surface antigen and HBV DNA. You should immunize your patients with inflammatory bowel disease. You can use the newer vaccine if it's available to you. It'll be more effective in only 2 immunizations. You need to verify that your individual with inflammatory bowel disease has actually developed antibodies, okay? And if there's, prior to using the inflammatory bowel disease drugs, check or recheck surface antigen, anti-HB core, HBV DNA, to be sure you know what you're dealing with, okay? And use nucleotide analog drugs for those at risk for reactivation. And then the last thing to point out is that even when you're done with your immunotherapy, 6 to 12 months of consolidation nucleoside analog treatment after cessation is recommended and really required. So with that, I'm going to thank you and turn the forum back to Flo.
Thank you very much, Dr. Carey. I liked it a lot because this is indeed so important. Vaccination of patients with IBD in general, and particularly for hepatitis B. So you answered already questions that came up in the chat box while you were talking, and while I asked everyone to come on for the panel, all of the speakers, Dr. Cohen and Dr. Falloon, I want to ask you one question. What about hepatitis C? So if a patient has hepatitis C, high titers of HCV, do you worry about that with biologics or any of the small molecules we use in IBD?
Not so much. Not so much. I mean, hepatitis C is now so treatable that it's just easy to treat, right? And unlike hepatitis B that sets up shop forever, once you've eradicated hepatitis C, it's gone, and you don't need to worry about it any longer. So if there's a latitude to give an individual 8 to 12 weeks of hepatitis C treatment, sure, do it before you start immunomodulatory therapy. But I don't think that's required.
Thank you very much. Very clear answer. And thank you for the presentation. I hand it over to the clinical director for IBD and co-section head, Dr. Cohen.
Thanks, Flo, and thanks for all these great talks. And I just want to remind everybody that normally while we end this program at 7:15, because we had such a great group of speakers, we've extended to 7:30. So with that, I'm going to turn it over to Dr. Falloon to lead us into some of the cases. And we ask all the panelists to turn on your cameras and we'll test you with these.
So we have a 33-year-old female with a 4-year history of axial spondyloarthritis and ileocolonic Crohn's disease. She's on adalimumab every other week and also on azathioprine. She comes in with worsening diarrhea, having 8 bowel movements per day, abdominal pain, and nausea. She has a CT scan on admission that shows a stricture with upstream internal penetrating complications. Her CRP is elevated to 13. Her fecal calprotectin is elevated to 480. Her adalimumab trough is 8, and she doesn't have any antibodies. She undergoes an uncomplicated ileocecal resection and is started on post-op ustekinumab. Her GI symptoms resolve, but she says she's developing progressive back pain and morning stiffness. She has a 6-month colonoscopy that shows Rutgers I0 disease, as you can see in the pictures endoscopically below. She's having formed bowel movements every day too, no abdominal pain, and no blood per rectum. Her CRP is still elevated but improved. It's now 7. Her fecal calprotectin has normalized to 26.
Katie, I think your slides aren't progressing. Maybe switch it to a slideshow and then go forward.
See.
I think the point here that Katie's making is that we have a patient now who, from a GI perspective, is in a surgical and endoscopic remission, but now they had stopped and they're on ustekinumab now after previously having their spondyloarthropathy controlled with adalimumab. So I guess the question for you, Dr. Husney, is what do we do in these situations? You know, from a GI perspective, we've got a stable patient, we're happy, but I guess you're not so happy because their joints are flaring. So if the patient's doing well on ustekinumab, what's your threshold to ask us to change therapy versus what can you do to add on to the ustekinumab to control their joints?
So the IL-12/23 ustekinumab is pretty well known in our literature for much more mild peripheral arthritis. So for axial symptoms, we probably would have liked to be in on the decision earlier, meaning so post-op I would have thought about starting something else. Even though I know they've flared on a TNF, but maybe switch to a different TNF. But IL-12/23 is probably not something that we would use. So we would expect the arthritis to come back. And then also important, again, to emphasize, what is really coming back? Is this true arthritis? Is this, axial symptoms, peripheral symptoms to help?
And so if we were to wind up switching therapy, what do you do in terms of disease monitoring? What is the guidance you would give us as the gastroenterologist in terms of how we're going to monitor response? Is this something that's all done by you, or is it something that we should be asking in particular when we're seeing the patient in follow-up?
Sure. I think there was a question in the chat about SED rate and CRP, so maybe I'll take on that question while I'm doing this case, because I think it's really great that we both are, meaning GI and Rheum, are very comfortable looking at these trends of CRP and SED rates. It's very confusing, when you have two diseases because you don't know how much there might be subclinical inflammatory changes in one over the other and how much, this was truly representative of the joint or how much this may be representative of a combination of their Crohn's or UC flares. So we do use it. But we don't use it alone. So like you said, it would not be something we would expect you to wait in your offices and not refer to us until the CRP is high. Like that's not something that I would do because as you know, it's very nonspecific. And so we do really rely on the morning stiffness, whether or not we see a joint that, is inflamed, whether there's imaging changes that we can gather. So we would need all of the above.
And Dr. Ruggiero, who now is joining our panel for the GI perspective, I wanted to get your feeling about, Dr. Husney talked about NSAID use during her presentation. So what's your advice to patients in terms of managing these joint symptoms with NSAIDs?
Yeah, so I think Elaine did a good job of kind of dispelling the myth that NSAIDs are the evil devil for IBD. And while I don't want to throw caution to the wind and say we should use high doses, and because we also have to worry about the kidneys and other processes, I think my guidance when patients ask me about NSAIDs now, it's probably like anything, obviously, ideally in moderation for short periods of time. The problem with this case is, as Elaine said, I know you're not asking the question about axial arthritis. I think NSAIDs are okay short term, but we're still going to need to have something long term. And my quick hit, because I know there are a lot of questions, are this would be a patient I would consider infliximab plus minus methotrexate with proactive monitoring. And I think we are entering the era of possible combination biologics. And so the other part of this is, would you actually give the ustekinumab and potentially consider an anti-TNF? But that's a little off topic and I'll stop there. But NSAIDs are probably okay just not long-term high doses.
Great. So Steve, I think maybe we can move on to the case 2 in the interest of time.
I can start talking about it while we're pulling up the slide. It's a 58-year-old gentleman who has a 41-year history of Crohn's disease, previously on Humira, and had a subtotal colectomy with end ileostomy 5 years ago for a sigmoid stricture. He's now off medical therapy and coming in with what he calls irritation around the stoma site, and he's having some trouble pouching because of it. He's not having any change in his ostomy output. He's still emptying his bag around 3 to 4 times per day when it's half full. He's having occasional bloating but no abdominal pain and some intermittent discharge from the rectum. Next slide, please. He's seen by dermatology, who takes a look and diagnoses him with pyoderma. And then he undergoes ileoscopy, the top 2 pictures there on the right, that looks endoscopically normal and on pathology is also normal. And then the rectum is also scoped, and he has erythematous ulcerated mucosa there with the stricture at 15 centimeters proximal to the anus that can only be passed with an XP scope. You can see that in the bottom 2 pictures. Biopsies are taken and there's no metaplasia, granulomas, or dysplasia.
So great. This can be a really challenging situation for our patients with stomas. So Dr. Fernandez, I think we had the most questions in the chat box for dermatology, which goes to show how little GIs know about dermatology. So I just wanted to get your thoughts about, is this something that we can control without using a biologic? What would be your approach in this patient?
Yeah, the peristomal ulcer looked relatively small. And I think peristomal Pyoderma Gangrenosum, I showed a picture in my presentation that I think was straightforward, but in real practice, I think it can be quite challenging to distinguish peristomal Pyoderma Gangrenosum from ulceration secondary to irritation or allergic inflammation because of adhesives around the stoma site. It's a real challenge. So we will often start very conservative because even biopsies are not going to help you in that situation. And I think looking at that photograph with the size of the ulcer, we would probably start by trying to make sure that ulcer bed stays as clean as possible, minimize bacterial overgrowth because that will slow down healing, and start with a trial of intralesional Kenalog injections around the border of that ulceration and measure it at every encounter and get a sense about whether it will start to heal with simple, conservative, non-systemic approaches.
There was a question that came up in the chat box about communicating the expectations to the patient about how long it can take for these to heal. So what should we tell patients in terms of their expectation?
I think, especially peristomal Pyoderma Gangrenosum, it's important to communicate to patients that they do need to be patient, that healing is not fast. The larger the ulcer, the slower it's going to be, but also just all of the different things that come into play with healing, and especially around a stoma site. Again, even if it is primarily PG, there is often irritation, secondary inflammation because of adhesive. It is hard to control bacterial overgrowth when that stoma is covered. The ulcers are often usually covered. And so it takes time. And I think the biggest issue we see with patients is if you can control their pain, they tend to be willing to be more patient than if they are in pain. So that's a big goal of ours initially in minimizing bacterial overgrowth. And even, a trial of corticosteroids intralesionally can often help with the pain and give you a sense about what is the best strategy moving forward to get this to heal.
Miguel, this patient has a retained rectum that seems still pretty inflamed. And I know we learned through the talks that PG can mirror disease activity, but also not mirror disease activity. What would you advise the patient in terms of their retained rectum here?
Yeah, so I think Katie did a nice job of saying there's variable parallel course, as you just stated. These are tough because obviously the pathergy with the ostomy is going to be such as Dr. Fernandez just pointed out. So I think the options and the expectations I set to the patient is, do we undergo a completion proctocolectomy, resite the stoma if needed, and or start biologic therapies, which again, anti-TNFs historically have been the best treatment for this. And then do you also consider a pouch of the patient? Do you actually try a J pouch? And we can get into the implications of some of the extraintestinal manifestations and impact on possible future pouchitis and complications and immune-mediated disease. But this is a patient in my mind that's probably headed towards a biologic and an anti-TNF. I think the rectum, I'd feel uncomfortable leaving that in place, so I'd probably recommend surgery. But I'd also have a very honest discussion with the patient that peristomal lesion may not heal without additional biologic therapy. And I agree, the intralesional injections are great, but I'm just worried this is going to continue.
Our last case is a 28-year-old gentleman. He has PSC and ulcerative colitis. He was previously on mesalamine, and he comes to clinic with diarrhea and bloody stools. He's scoped. You can see the pictures on the right. He has Mayo 2 disease on the left side. The pathology comes back chronic active colitis without CMV. And he started on infliximab at 5 mg/kg and goes into remission. His repeat scope shows quiescent disease. And 5 years later, his PSC progresses, and he ultimately gets listed and undergoes an uncomplicated liver transplant. And post-op, he started on prednisone, MMF, and Tacro.
So this was a very timely case because I think the last question in the chat was, can PSC patients who underwent liver transplant for decompensation be resumed on their biologics while on anti-rejection medication? So Dr. Carey, can you give us some insight into how you would approach this patient who was previously on infliximab and now had a liver transplant?
Right. Well, the answer, of course, is it all depends. I mean, the less you use, the better, particularly in the first 9 to 12 months after a transplant. The worry that I would have is increased susceptibility to infection. But as time goes on after the transplant, the risk of infection goes way, way down. And so, I think it's a balancing act between the time after transplant, the severity of the ulcerative colitis, but there's no absolute contraindication to the use of infliximab in this context. I would just be careful about it and delay it for a while if you could.
Do you adjust the doses of your anti-rejection meds based on the IBD therapy a patient may be on?
Not so much. I usually adjust it based on levels, particularly Tacro levels. Right.
So infliximab is not yet restarted, and he undergoes a screening colonoscopy at 1 year that shows Mayo 1 disease on the left side. Path is again chronic active colitis, but no CMV. And this time he does have a foci of low-grade dysplasia on a random biopsy of the sigmoid colon.
So I guess there's a couple pieces to this. First, I'll start with the active disease piece, Miguel. What's your approach in terms of positioning agents for patients who may be on immunosuppression for a transplant?
Yeah, so I think, well, to Bill's point, I think this is a patient that you certainly could restart an anti-TNF, and I think the era has gone by where we're afraid of starting some monoclonal antibodies like infliximab because of a delay in treatment and immunogenicity. So that would be, I'd be okay with that. Obviously, I'd work very closely with our transplant hepatologist to make sure we're fine. The second part is, you didn't ask about the dysplasia. I don't know if you want me to answer that.
Yeah, so the second piece was, okay, so this patient has dysplasia, obviously. I guess one question is, does the fact that they had a transplant for their PSC change the dysplasia risk in the patient? Is it the same? And is this a patient then you would send to a surgery?
Yeah, this is always tough. So if it's not a raised lesion, not visible in the setting of flat mucosa that's inflamed, and it's a single foci, and it's not in the right colon, which a lot of these are usually right colonic cancers or dysplastic areas, I would give an attempt at medical therapy. And I have seen some of these low-grade dysplasias melt away. However, we need to be careful because the data on low-grade dysplasia and flat mucosa progressing to high-grade or cancers is high enough that still the right answer on the boards is a colectomy in somebody with PSC. But in reality, I'd probably treat with an anti-TNF. I also find tofacitinib might be an appealing option in this case, but then we would have to get into what's a JAK inhibitor do in transplant. And then I'd watch them closely. I'd probably do chromoendoscopy. And if they have more low-grade dysplasia or multifocal, then yes, the answer is a colectomy. But I'd probably try to still medically treat them first.
Dr. Carey, can you tell us anything about dysplasia risk aside from this patient that had low-grade dysplasia and a patient that's had a transplant for their PSC? Does that modify their cancer risk as we know it at all?
You know, I don't know the answer to that question. I just don't know.
All right. Well, we can't know the answers to everything, right? So I think with that, I want to thank the panel for some excellent discussions today, great presentations. I think these are areas that all of us need some help with, and it just really gets to the multidisciplinary piece of IBD care, and we can't do it by ourselves. We really need good consultants working along with us. And we want to, with our closing announcement, so Steve, you can put up the closing slides. To receive your CME credit, you can scan the QR code on your screen with your phone and follow the prompts. And tonight's activity also qualifies the American Board of Medicine, American Board of Surgery, the American Board of Pediatrics, MOC. The credit claim details and PowerPoint handouts are going to be sent to everybody tomorrow, so be on the lookout for that. And this has also been recorded, so you can play it back again if you wish. And then we want to just ask you to join us for the next live from Cleveland Clinic broadcast, which is going to be on October 13th. And it's how to approach routine and complex abdominal wall hernias, led by Dr. Michael Rosen and Dr. Matthew Walsh from the DDSI. And with that, we want to tell everybody to have a great night, and thanks for joining us.